Hello, my name is Ruben Mesa, and I'm a hematologist at the Mayo Clinic who focuses on myeloproliferative neoplasms and polycythemia vera. I'll be focusing today on the topic of polycythemia vera, providing some background on the disease, as well as focusing on a variety of questions that have been pre-submitted. Now, polycythemia vera is a myeloproliferative neoplasm. Now, what do I mean by that? The bone marrow is where our body creates blood, the red blood cells that carry oxygen, the white cells that fight infection, and the platelets that help the blood to clot. There are many different illnesses that can affect the bone marrow. One of these family of illnesses are myeloproliferative neoplasms. These are a type of bone marrow disease. They are, most accurately, a type of a chronic leukemia that can affect the body in a variety of ways. Polycythemia vera is one of the myeloproliferative neoplasms, or MPNs. They've been referred to in the past as myeloproliferative disorders, or MPDs. Polycythemia vera is really characterized by an increase in the red blood cell number, but patients can have increases in either the white cells and or the platelets. It is a disease that can affect people in a variety of ways, both in the short term and in the long term. In the short term, this is an MPN that is related to other MPNs, essential thrombocythemia, which is a disease characterized by too many platelets, or the more advanced form of MPNs, which we refer to as myelofibrosis. All of the MPNs, as chronic leukemias, have some risk of changing into acute leukemia. However, that risk occurs for the minority of individuals with polycythemia vera. First, how are we made aware that someone might have polycythemia vera? Typically, people are found to have the disease either one, at the time of a general physical, their blood counts are found to be elevated without a good secondary explanation. Or individuals have presented to their doctor because they're not feeling well, because they've had a blood clot or a bleeding event, or because they're having other symptoms that we could associate with polycythemia vera, such as difficulties with headaches, migraines, itching, or other difficulties. Polycythemia vera is diagnosed utilizing several different aspects. Fundamentally, it's seeing an increase in the red blood cells without a secondary cause. Secondary causes for increasing the counts can be many. For red blood cells in particular, it can be the body needing oxygen that it's not receiving. So common reasons for that are individuals who live at very high altitude, individuals who have certain heart or lung disease, individuals who are smokers, individuals who have sleep apnea, or individuals that are born with hemoglobin, the oxygen-carrying molecule, that is slightly different than it should be. We diagnose polycythemia vera in several ways. First is trying to identify whether there is a genetic mutation which we associate with polycythemia vera in the potential patient. The JAK2 V617F is such a mutation. It's a mutation that we're not born with, but typically we acquire during life. It's present in about 95% of patients with polycythemia vera. About another 4% of patients with polycythemia vera will have an alternative mutation in JAK2 that is called the JAK2 exon 12 mutation. Between these two mutations, they are present in the vast majority, maybe 98 to 99% of patients with polycythemia vera. There still are a small subset of individuals that will not have one of these mutations. Other features that we look for to confirm the diagnosis include, one, the decrease in the serum erythropoietin level, a hormone normally involved with regulating the creation of the blood, as well as other secondary features of the disease. And finally, the appearance of the bone marrow biopsy, where there are features in the bone marrow that are different in patients who have polycythemia vera than those who have an increase in the red cells for other reasons. After the disease is diagnosed, we try to assess the burden of the disease. What is the risk with the disease? What are the symptoms? In terms of the risks, we assess it in terms of a risk of a blood clot, a bleeding event, or the risk of the disease progressing. Many features are important. As we age, the disease can give us greater risk. As we have heart disease or lung disease or risk of heart attack or stroke, these can add to the risk of polycythemia vera. Having previously had a blood clot or bleeding event is associated with a higher risk. A blood clot in the legs or the lungs or elsewhere in the body. We also recognize that having a high white blood cell count may increase the risk of having a blood clot or bleeding event. We also assess the symptom burden. Does someone have no symptoms or many symptoms? Symptoms that we've recognized associated with the disease very commonly include fatigue, can include itching, can include a variety of other difficulties, including night sweats, fatigue, as I mentioned, headaches, migraines, difficulties with insomnia. And as people have more progressive disease, can include other aspects, such as enlargement of the spleen, filling up early, or even inadvertent weight loss. We've now assessed the risk and the symptoms with the disease. As we assess polycythemia vera, we're concerned with both short-term issues and long-term issues. In the short term, we're concerned about the symptoms. We're concerned about risk of blood clots and bleeding. Over time, we have long-term concerns. Concerns that the disease can progress to post-PV myelofibrosis. Patients with post-PV myelofibrosis have scarring that develops in the bone marrow. They can have enlargement of the spleen. They can have worsening symptoms. They can have certain symptoms that we associate more with myelofibrosis. Those sorts of symptoms include weight loss, bone pain, fevers. They can have a decrease in the blood counts and ironically end up becoming anemic or have a drop in the platelet count. The other long-term risk is the risk of progression toward acute myeloid leukemia, or what we call MPN blast phase. This occurs in a minority, but if it occurs, it can be a very problematic change. It can be a life-threatening change. Now, how do we treat polycythemia vera? First, we recognize that in the majority of individuals, a low-dose amount of aspirin, 81 or 100 milligrams, may help to decrease the risk of blood clots and bleeding, particularly in individuals who do not have any allergy or contraindication to aspirin. Next, we recognize that control of the hematocrit is important, whether it be through phlebotomy, which is taking blood off, such as the equivalent of donating blood, or whether medications are used to control the hematocrit. Studies have been done and have helped to demonstrate that a hematocrit of 45% or less is helpful. In certain individuals, a value of less can be considered, including in women and in individuals that still have many symptoms at 45. The hematocrit is the percent of blood by volume that are red blood cells. So literally in the laboratory, they spin a tube of your blood down, and the percentage that are the red blood cells that segregate to the bottom of that tube is the hematocrit. So pretty much in all patients, it's a question of aspirin and of hematocrit control. In a selected group of patients, and here is where much of the discussion comes between you and your physician, individuals can benefit from what we call cytoreductive therapy, or medicines designed to lower the blood counts with a goal of trying to decrease the risk of blood clots and bleeding and potentially improve symptoms or even improve the risk of progression. Patients who require a cytoreduction typically are individuals who are older, who have symptoms, who previously had a blood clot or bleeding event, are intolerant to numerous phlebotomies, or having difficulty controlling their disease. So flipping it around, individuals who don't require cytoreduction are primarily those individuals who are younger, really don't tend to have symptoms, have not had a blood clot or bleeding event in the past and really are relatively minimally affected by their disease. They may well be okay to be managed with aspirin and phlebotomy. Now, amongst cytoreductive therapies, they fall into categories of frontline and second line. Historically, the most utilized cytoreductive therapy has been hydroxyurea. It is a pill. It can help to lower the counts. For many individuals, they can't feel well on this medicine. Side effects can occur, can increase sensitivity to the sun, can increase risks of skin cancer, of ulceration to the legs or to the mouth. It may be slightly increased with other secondary cancers and might have a slight impact on the risk of progression to acute leukemia, although it's not clear that hydroxyurea by itself increases that risk of leukemia alone. Next, there is interferon, or the long-acting forms of interferon that include pegylated interferon alpha-2A, also known by the trade name of Pegasus, or proline pegylated interferon alpha-2B, which is currently being developed by AOP Pharma in Europe and Pharmacentia. That agent is being currently tested in the PROUD-PV studies in patients with PV randomized between Hydrea and proline pegylated interferon alpha-2B. The pegylated interferon alpha-2A is currently being tested in an MPD Research Consortium clinical trial of hydroxyurea versus the Pegasus, or pegylated interferon alpha-2A, in newly diagnosed high-risk patients with PV in the US and Europe. So that is frontline. Second line includes JAK inhibition. The JAK inhibitor ruxolitinib recently was FDA approved in the US for individuals with polycythemia vera that were resistant or intolerant to hydroxyurea. This was based on the RESPONSE study, a study I was involved in which individuals with polycythemia vera who had failed hydroxyurea and had other problematic disease features such as ongoing need for phlebotomy, enlarged spleen, difficult symptoms, were randomized to best alternative therapy or ruxolitinib, and found that ruxolitinib was superior for control of hematocrit, symptoms, and maybe even have a favorable impact on risk of thrombotic events in patients with polycythemia vera. So now ruxolitinib has been indicated as clear second line. Other agents are in development, but for most individuals for polycythemia vera, the discussion of cytoreduction involves a discussion around the agents of hydroxyurea, the interferons, and ruxolitinib, at least in 2015. Now, as we monitor patients with polycythemia vera, we're monitoring several things. We're monitoring whether the therapies we're using are accomplishing their goals. Are they normalizing counts? Are they medicines that patients are tolerating well? Do you feel well on the medicine? Is it reversing symptoms that are difficult with the disease? We track over time to make sure that there is no difficulties or toxicities from the medicine, that there's no evidence of difficulties from the disease, such as blood clots or bleeding. And then we monitor for any changes in the disease to suggest progression, whether changes in the blood counts, changes in the bone marrow, changes in the symptoms, or enlargement of the spleen. So with that as a background on the diagnosis, prognosis, and management of polycythemia vera, I will now refer to some of the pre-submitted questions to give some further information about polycythemia vera. The first question: when a patient is found to have the JAK2 V617F gene mutation, why not start them on interferon immediately, slow the progression of PV? Shouldn't it be started as soon as the JAK2 mutation is present? So the JAK2 mutation is present, as I mentioned, in the vast majority of patients with polycythemia vera. Interferon, amongst the therapies that I've discussed, is one in which we have seen in a subset of individuals, maybe 40 to 50%, that it can decrease the level of the JAK2 mutation in the blood. Overall, we think that that is likely a favorable effective response, although we don't know that for certain. We don't know for certain whether decreasing the level of the JAK2 mutation is and should be a goal of the therapy. It has been speculated in single-arm studies that pegylated interferon may help delay progression in the disease. It's difficult to know whether with one individual has a medication stopped the disease from progressing compared to where they would have been before, because there's not anything to compare it against. The randomized upfront studies, the MPDRC study, as well as the AOP study, hopefully will give us further information as to whether the interferons truly do decrease progression, what is the magnitude of that impact, and then if so, are there any markers that are helpful in predicting that, whether it's JAK2 or a different marker. At the moment, I can't say that we know enough about the benefit of the interferons to say that we should be using them broadly in everyone, or that if we do, the JAK2 is the test we need to monitor to assess whether it's having the impact that we wish. Next question. I'm a male, 64 years of age, a U.S. Naval Vietnam veteran, PV JAK2 mutated. Are there any studies or documentation of PV and exposure to Agent Orange? At the moment, for many different blood cancers, there has been an association with exposure to Agent Orange. And a list that the Veterans Administration refers to as a presumptive list, meaning that it is reasonable to assume that individuals that had significant Agent exposure and Agent Orange exposure and have these uncommon blood cancers, that there could be a link. The reason for such a list is that with one individual, it is impossible to say with one patient in front of me what the exact cause of their disease was. Did they get their P. vera by aging? That is the most common link that we're aware of. Is it related to an exposure, whether it be occupational or in this sense related to military service with Agent Orange, which has been associated with many other cancers. At the moment, there are efforts undergoing to try to have the myeloproliferative neoplasms added to the presumptive list of VA-associated Agent Orange exposures. I'm unaware of any definitive data, and it is difficult to obtain that show without equivocation that Agent Orange exposure directly leads to an MPN. I think in the end, probably the greatest clarity we will have is at least having that on the presumptive list as a likely contributor. Next question. I was diagnosed with a clot that led into my hepatic vein, into my liver, what we call Budd-Chiari syndrome. I'm JAK2 mutated, and my regimen includes hydroxyurea, and I was diagnosed in September of 1988. My counts now seem to be much more erratic than when I was first diagnosed, and the dose of the hydroxyurea has been changed. It does not seem like hydroxyurea is any longer working for me. When in general are patients moved to another form of treatment? Again, which medication an individual should be on is a very complicated matter and clearly can't answer what is best for one individual. However, I can try to answer the spirit of the question: how do we consider a medication to be successful? When do we consider it to not be successful? For a medication to be successful, it needs to be accomplishing the goal that we set out for the patient as a hematologist. Is it normalizing the blood counts? Is it avoiding the development of a new blood clot or bleeding event? All those are key. Is it improving symptoms? And then finally, is it not having unexpected toxicities or side effects that are unacceptable? If an individual is having counts that are difficult to control on a medication, sometimes that is a sign that we need to be considering an alternative medication. And it would not be uncommon that individuals, after a long period of time, the characteristics of their disease change and may need a different medicine. Indeed, as I'm monitoring patients, I typically, as I visit with them, I expect their blood counts to be about the same. I look at the rate of any phlebotomies and hope that that rate is low, that they're feeling about the same, that they're not having unexpected toxicities, and if so, may consider an alternative medication. In the US, ruxolitinib would fall into that group, as well as individuals may consider interferon, if nothing else, in a clinical trial setting for individuals that have failed hydroxyurea previously. There is an NPDRC clinical trial of pegylated interferon for patients who have failed hydroxyurea. Next question. Does polycythemia vera have stages? If yes, what are the symptoms? How do I know what stage I'm in? Etc. In general, the blood diseases do not have stages that are easily synonymous with how we think of stages in other types of cancers. In cancers such as breast cancer, prostate cancer, colon cancer, there are very clear stages, sometimes 1 through 4, that are defined by the extent of the cancer, its size, lymph node involvement, and whether it is spread. In the blood diseases, since the blood is very free-flowing and changes in the bone marrow tend to be present throughout the body, whether we check for it in the hip or elsewhere in the body, there aren't really the equivalent of stages. With polycythemia vera, I'd refer you back to our discussion a bit around risks, as well as the burden of the disease. I view individuals really as having earlier disease or later disease. And the earlier versus later is not necessarily related to the time period an individual has had the disease. Some individuals have difficult or later type disease from the moment we diagnose them, and others can have earlier features for a long time. Earlier being less in the way of symptoms, lower risk of blood clots and bleeding, and clearly no movement toward myelofibrosis or acute leukemia. So on the bone marrow, no significant scarring, hopefully no chromosomal changes, no increase in blasts, and no significant splenomegaly. The development of any of these 4 latter features would make me concerned that there is further movement toward the later phases of the disease, or post-PV myelofibrosis, or to even acute leukemia. Next, I have found that wrapping my legs in ice packs can provide me some relief, particularly for very difficult itching. Usually I get numb in about 20 minutes and the itching subsides. I haven't found anything else that works. Do you have any suggestions? Itching can be a very difficult symptom of polycythemia vera. This is the individual's question. This is a more difficult case with the extreme of the intervention. We believe that the itching has its origin potentially from white blood cells from the disease infiltrating into the skin and releasing different proteins and other substances into the skin that really lead to the itching. Several things have been beneficial, and not one thing works for all individuals. Clearly, for some individuals, this itching sometimes is even brought about more by bathing or warm water. First, certain mechanical things have been helpful for some patients. Some patients find if they air dry as opposed to toweling off, that can be helpful in that the process of toweling sometimes sets off this reaction in the skin. Individuals sometimes have found that UV light can be helpful, although be mindful that UV light still can give us risk of sun damage or skin injury, so typically don't recommend that people do that in the long term. People have sometimes found that antidepressants can be helpful. Not that this is depression, but that the medications, the SSRIs, such as Paxil and Zoloft, potentially help to inhibit serotonin that may be involved with this itching response. Interferons sometimes have been helpful with itching. Ruxolitinib clearly can be helpful in people with difficult itching. So we look at a variety of different factors that can be helpful. Nothing wrong with the cold pack approach, but if it's something that would need to be done frequently, it might be a consideration of one of those medications I discussed. Next, I've had P Vera with an elevated red and white cell count. My white cell count has been 30 to 35, or depending upon your scale, 30 to 35,000 over the last 4 years. Is there a direct ill effect from an elevated white count? Do I tend to get more ill because of it? An elevated white count has been associated perhaps with a slightly higher risk of moving towards either myelofibrosis, as well as a higher risk of blood clots and bleeding. It may be a factor in terms of consideration whether a cytoreductive medication should be used or not. In general, it has not been felt that the white cell count, when elevated, is a direct sign that the immune system is not working as it should be. So in general, we don't tend to see unexpected infections, specifically unexpected bacterial, viral, or fungal infections, in patients with PV with an elevation in the white count. So in general, we don't think that there is a higher risk, but nor should one ignore signs of infection if they develop. Next, I'm 41 and was diagnosed 14 plus months after onset of PV. I had a series of TIAs, vision disturbances, and other difficulties, and have probable MS. My doctor tells me my PV is under control, but I'm still having quite a few issues. Can the blood work indicate that the disease is under control? Judging whether the disease is under control is a combination of several things, which include the blood counts, include the symptoms, the rate of phlebotomy. It is important to know that polycythemia vera, although it can cause many symptoms, is not necessarily the only thing impacting an individual's health. And as physicians, we always have to be mindful, particularly if there are other diseases or other possible diseases at play, to not overly attribute all of the symptoms to the polycythemia vera. There are individuals, however, I will say, who have difficulties with symptoms even after their counts have been adequately controlled. And this is most common in individuals who are on phlebotomy and aspirin alone, sometimes still don't feel well, in particular if they have significant iron deficiency. Phlebotomy helps to control the red blood cell count, in part by creating a state of iron deficiency, which can cause or even aggravate other symptoms. So I'll answer this question by saying it depends, but be mindful that a normal CBC does not necessarily mean that a patient with polycythemia vera, that the disease is fully under the control that we wish. And finally, is the hematocrit the single most important number to watch when gauging PV? Or are there other aspects in terms of monitoring the disease? I would say that as we try to monitor the disease, the goal is to be decreasing the risk of blood clots and bleeding, tolerating the medication well, ideally getting the counts under the goal control that we wish. Improving the number on the page in terms of the blood counts is helpful, but it's most helpful if that correlates with the reversal of the other symptoms or difficulty that an individual is having. And sometimes that is where we consider the addition of other medications or changing medications from hydrea to interferon or a JAK inhibitor if we see that there are still significant difficulties that remain that we think are attributable to the disease and that have not been normalized by improving the blood counts. So overall, I would conclude this by letting patients with polycythemia vera know that they should be very hopeful. As a field, we continue to strive to best understand why P vera develops, why does it have the potential of progression, and is there a way that we can cure the disease? At the moment, we do not have a cure. Our therapies really need to be looked as a therapy of a chronic disease in which we're looking to control the disease. But know that we are looking for a cure, as well as other ways that we can be more definitive about decreasing the risk of progression and being more complete in terms of decreasing the symptoms and other burden which patients with polycythemia vera can experience. All my best.